Dr. Sidney Rabinowitz is a people person, and that was never made more clear than in this podcast interview with him. We just finished the interview, and I have to say, he is truly an exemplary plastic surgeon, how he connects to people. I am not someone who really loves hand call when I was taking ER call. In fact, I really hated doing hand surgery injuries probably my whole career, which is why probably I ran screaming into craniofacial as a specialty. And there were a number of times when I would be faced with some sort of complicated hand injury in the ER, and I would contact Sid, and invariably he would help me out. And that's not normal in this. I don't know. I don't know about the rest of the country, but certainly not in North Jersey. And he was always gracious. He was really kind. And he really was wanting to help others, his fellow plastic surgeons, as well as, most importantly, the patients. And after we finished talking, he continued to talk to me about, especially when he was a younger partner, he would talk to patients for quite some time, sometimes up to a half hour. And the senior partner would notice this and say, "Why are you taking so long with the patient?" And he said, "Well, I needed to know about the patient and the problem." And the senior partner would just not understand. But we need more of those surgeons in our lives. And it was very telling. He said, if I got through a very good history and talked to the patient, listened to them, understood them, I could figure out the diagnosis even before I examined them 90% of the time. And that is the mark of a great clinician and someone who is so skilled in terms of connecting to patients. And that is a skill that I think most people should have in life. It's something Dr. Rabinowitz has in abundance, and it's something that I have and will continue to strive for with the people around me and my patients. And he is one of those old school generalists who does handle so many different issues, particularly in terms of trauma, reconstruction, and of course, hand. So without any further ado, this is my interview with Dr. Sidney Rabinowitz. All right, welcome back to another edition of Botox and Burpees, the surgical series. I have with me one of the great surgeons in New Jersey. This is Dr. Sidney Rabinowitz. I've known him for a very long time, and he has a couple outstanding characteristics. One is he is, they say nice is sort of pejorative, but in this case, being nice is the best way to describe Dr. Rabinowitz. He is truly a kind, caring individual. I will say one of the tough things about being a plastic surgeon, especially when you're in the thick of things, is that you have to take a fair amount of emergency room call. And Dr. Rabinowitz is, in my mind, one of the most selfless and helpful people I've ever seen in plastic surgery in regards to aiding other surgeons, aiding patients, usually in a time of need. And we can get into that a little bit later. But let me intro Dr. Rabinowitz and give you a little bit of his background before we get into the meat of things. So Dr. Rabinowitz graduated with a degree in chemical engineering at WashU, Washington University in St. Louis, and then got his medical degree at NYU School of Medicine in New York. You did your general surgery residency, so you're an old school surgeon where you did a full general surgery residency at SUNY Brooklyn, and then subsequently did a plastic surgery residency at UMD&J New Jersey Medical School here in our home state, and then did a hand and microsurgery fellowship at California Pacific Medical Center in San Francisco, California. So you're triple board certified in plastic surgery, general surgery, as well as hand and microsurgery. Now, who was your mentor at California Pacific Medical Center for hand and micro?
That was Len Gordon. Len Gordon is a Greg Bunke disciple from Davies Medical Center, and he's an orthopedically trained hand surgeon. But interestingly, he's from New Zealand, and he also trained in plastic surgery. So it was kind of fascinating he, although he's orthopedics, he loves getting plastic surgery fellows to do his orthopedic fellowship.
I know a couple of people who were plastics guys who did, say, like an ortho hand fellowship, like at HSS or at your institution. much more wide-ranging hand fellowship, I would say, from the experiences that I've heard from them. But then after that, you're now chief of the hand surgery section at Hackensack University Medical Center, and you're the head of plastic surgery at the Department of Surgery at Valley Hospital, which recently moved and is now in Paramus, New Jersey, which was quite an event. And like I said, I've known you for ongoing event right now, yes. And I've known you for a long time, and like I said, I think of you as one of the best around my practice area for sure. So I never really talked to you about this, but I really wanted to first ask you about your training experiences and whether or not what was it that sort of led you into plastic surgery or micro hand in particular? What kind of experiences, or was there anything really formative that sort of put you on that path?
It was a determined happenstance from the start. And first of all, thank you for that kind introduction. When you hear those words, boy, I sound like a really nice guy. And again, hopefully not in pejorative, because, they say nice guys finish last, hopefully not this time.
Right.
I was one of those people that never wanted to be a doctor growing up, or never. Let me rephrase that. I was not one of those people that wanted to be a doctor since I was 5 years old. As a matter of fact, I dropped out of nursery school, which is now called preschool, and because I came home and I told my mother, I'm not going back. I have all the same toys at home. And she thought it was a compelling argument. And so I stayed home for a year and then went to kindergarten. And then in kindergarten, she said, well, we have to go to first grade. And I said, well, school doesn't really appeal to me. And at that time, I was so fascinated with sanitation workers. I loved the garbage men. So much so that I used to sneak out of the house in the morning in my pajamas, watch them, and they all knew me because I did that routinely. I had several younger sisters, so my parents couldn't be concerned with me, and they let me sneak out. And I still remember being 5 years old and telling my mother, look, I'm not going to first grade. I'm going to be a garbage man, so I really don't need to read. And she said, okay, I'm fine with that. And then she was really smart. And then I said, well, wait a minute. How will I read the street signs? And she said, well, maybe just go to first grade. Take it from there. She was very smart about it. She didn't force me. I went to first grade, and thereafter, my education continued. But to answer your question about why medicine, as you said, I was a chemical engineer in college. And it was a little before they did biomechanical engineering. And my idea was that I was going to be a biomechanical engineer, and I was going to design myoelectric devices for amputees.
Wow.
I thought it was fascinating. I was always a STEM guy. I loved math. I loved equation. I loved when there was right and wrong. Shades of gray didn't appeal to me. I liked black and white. And it was really about my junior year in college, and I hope this is not too belaboring this whole discussion. Junior year in college, and this was before personal computers, as much as I loved my HP 41CV calculator, which was just stupendous, and I did love it, still do. I decided that I like people more. And you've alluded to that. I love people. I love talking to people. I love hearing people talk, even though I'm doing most of it now. So I made the switch in my junior year in college to pursue medicine. And fortunately, as an engineer, I had all the prerequisites, so I really didn't need to do much except take the MCAT, and the rest is history. Now, in terms of going into plastic surgery, there were a couple of events that led to that. At NYU, I really kind of loved the surgical specialties more than internal medicine. What I didn't like about internal medicine is that you treat people for 30 years and they still have the same diabetes. And what I liked about surgery is like a 2-hour movie. You have a beginning, you have an exciting middle, and then you have the end. And then in 2 hours, it's done and you have an answer, right?
Mm-hmm. Yep.
There was a problem. I fixed it. Move on. And I love that aspect of it. And I love being able to fix things. I used to teach woodworking in high school because I just love working with my hands. And then in terms of plastic surgery, I at first I was going to be an OBGYN, but then realized after I went to GYN clinic in downtown Manhattan that it really wasn't for me. And also babies tend to come at night after midnight, which didn't appeal to me. So I wanted general surgery. My father, unfortunately, had taken ill and was cared for by a very, very terrific doctor at Memorial Sloan Kettering. He was a colorectal surgeon, since retired. And I was so impressed with his demeanor. I was impressed with his professionalism. I was impressed with how he talked to us in a way, educated us, but at the same time was so professional and caring. So that may have been my first role model. So I thought general surgery, and that's why I entered into general surgery program. And then right about my second year in general surgery, I ended up at Long Island College Hospital doing a rotation in plastic surgery because it seemed kind of interesting and no one else wanted it. I worked with a doctor named Dr. Kaplan, and it was just me and him, and he took me under his wing. And I was smitten after a month with him. And what I loved about plastic surgery, and you'll probably echo those same words, Sam, is that men and women, so it's not like urology where it's all men, or GYN, it's all women. It's children, it's adults. And as opposed to trauma surgery, most of my patients will not die.
Right.
Okay. So I liked having healthier patients. And I love the fact that we operated on patients from head to toe. And I also like the aspect of plastic surgery that we were the problem solvers. And you know that to be true.
Yeah.
If someone else, whether it be orthopedics or neurosurgery or general surgery, if they have an open wound and they can't close it, they call us. We're like the firemen.
Yeah.
And I like being able to think out of the box and use knowledge to solve novel problems that perhaps are not written in black and white on the books, but you have to use your knowledge and be creative. So in a way, it's a merging for me of engineering and science and biology. I love it.
Yeah, that is what plastic surgery is. I had a mentor at Michigan, and he had a diagram of plastic surgery at the center of the surgical universe because we interfaced pretty much with everybody. We interfaced with vascular and ortho and oculoplastics and ENT and thoracic and every, like you said, head to toe. We had to be pretty familiar with the anatomy. We had to know a lot of the functional stuff, especially in the head and neck, which is pretty complicated. And then with the hands, and then like you said, any complicated issue with soft tissue, they really call us, and that is very much our calling, especially when we are in training for that. But then you also decided to go into hand and micro, which is a big part of your practice, not all of your practice, but a big part of your practice. And speaking about coming in at midnight and not wanting to do that, like there's a lot of hand injuries. It's the most common ER injury out there. So what led you to that? And you are still very much a very active micro and hand surgeon at this point. So what is it that appealed to you and still appeals to you at this point?
It does appeal to me. It still appeals to me. It was part desire and part practicality. When I was doing my plastics fellowship at Rutgers, my immediate supervisors were Doctors Rauscher, Dr. Boss, Dr. Bykoff, who were all in a group at Hackensack, and they were a dominant group in the hospital. My wife is from this area. She wanted to stay in this area. And they evidently thought that I was a good resident and wanted me to join the practice. But they said, we really need a hand surgeon. We had someone who did hand surgery. He left and went to South Jersey. We have Craig Hall, who's craniofacial. We have Bill Bost, who's microsurgery. Rauscher did a lot of breast and face and cosmetics. And we need someone to do hands. So there was some practicality to it. And they said, if you do that, we would love for you to join our practice. So it was partly because I wanted to work here and join this group, and I thought it was a great opportunity. But it also collided with my interest, which I like fine intrinsic work. The hand, as you mentioned, like head and neck, there's a whole lot of structures in a small area. Other little tidbits about hand surgery, usually 2 hours, right? And you sit down. It's a gentleman's surgery. There's very little blood loss. It's all under a tourniquet. So there's a lot of appeal to that. As you know, literally there's hundreds of operations in a small area, and they're all very nuanced. And like anything else, some of the procedures are hard to do, or some of the procedures are easy to do, but hard to do well. That's what I always like to say. So that appealed to me, that you have to really work hard at it and hone your skills and constantly re-educate yourself and learn more to be really good at that. So it worked out well for me.
Now, as a hand surgeon, and I have heard you at Hackensack M&M conferences, you have obviously a tremendous amount of knowledge. You are constantly, like you said, educating, re-educating yourself. So what is it that you strive? I mean, and like you said, there's so many operations and they are constantly evolving. And I'm sure that for all of us, what we did 10, 15, 20 years ago is different for many operations than what we do now. What do you do, or how do you approach your surgeries to make sure that you continually become better as a surgeon?
Well, that's a great question, because we do have to continue. Well, first of all, having residents around keeps you young, okay? Because the residents are constantly reading, and they'll read something esoteric and throw it at you. And if I've heard about it, great. If not, I'm learning about it because I want to keep up with them.
Right.
In hand surgery, the device companies, and I'm a big fan. I don't want to shamelessly plug anyone, but there's one company that I like quite a bit, and they've really done a great job in terms of, as far as I'm concerned, revolutionizing the problem of how do we mimic what ligaments do? That's the biggest problem in hand surgery, right? We know what tendons do. We could always borrow a tendon from somewhere else. We have excess tendons. But what we're bad at is ligament, because ligaments are very thick, relatively avascular, tough structures that are inelastic. And for years, we've tried ways of recreating it. We've gone to the foot and taken bone ligament bone grafts to try to fix scaphoid lunate injuries. We've tried burying them. We've tried putting bone tunnels and using ligaments. I'm sorry, using tendons to weave, but the tendons don't have the same elastic profile and recoil that ligaments do.
Yeah.
So one of the companies has been very, very ingenious in developing these bone anchors, and that to me has changed everything.
What company is it? It's okay, mention it.
This is Arthrex.
Oh, okay.
And they have these both titanium and bioabsorbable anchors that we use, and that really has changed everything. These are anchors in which we can put tendon grafts, or even synthetic suture tape or label tape, and they do everything that ligaments could do, and it's much easier. And it's kind of revolutionized how we do shoulder surgery, knee surgery, wrist surgery. I can now reconstruct the scapholunate ligament, and it will be very strong, and it will have the same tensile properties, and people will avoid things like bad arthritis later on down the road.
So these are the same technology they use for, say, like ligamentous injuries in the knee are the same ones you're using in the wrist to reconstruct disrupted ligaments there? Wow.
Absolutely.
Wait,
Yeah,
are you a consultant? Do you own shares in Arthrex? I'm just
we
wondering.
do not.
Oh, okay. Just wondering. Purely just from your own clinical experience. That's pretty cool.
It is.
Yeah.
I look at all companies and I'm constantly looking to see what products are produced and which ones would help me. And
Mhm.
I try them out. And they just have a strong array of products that I find works well
Mm.
and has done quite a bit. Like a perfect example of that is, let's say, you may have heard of skier's thumb. People or gamekeeper's thumb. At your thumb, you disrupt your ulnar collateral ligament at the MTP joint.
Mhm.
And for years, we would try to repair it, or we drill bone holes through the bones, which
Right.
are big bone tunnels, and use a tendon to weave it through. But
Mhm.
now we use these little swivel lock anchors
Mhm.
with suture tape. And the big difference is, whereas it used to be a 5-month recovery, is now an 8-week recovery.
Wow. Yeah.
Um, People who have thumb CMC arthritis, the most common arthritis in our hands,
Yeah.
it used to be a 4-month recovery from
Yeah.
doing procedures. Now, when we do these internal brace procedures, and you've heard these now because it's like what Aaron Rodgers had done with the
Yeah.
speed bridge.
Yeah.
Most football players now get the internal brace repair when you're
Right.
doing a CMC or thumb metacarpal joint,
Yeah.
and you're better in really 4 to 6 weeks now. It's
Yeah.
much quicker.
Yeah. It seemed to make sense. Like the Aaron Rodgers, the other tendon type repairs, ligamentous repairs, to have that resorbable type of structure that helps support it. I don't
Hmm.
know why we didn't think about it 20 years ago. I'm glad you guys are doing it now. It totally
Hmm.
makes sense. Um, so when you operate, then what do you do to set yourself up, or in your prep or in your routine, to make sure? Is there something you do every time you operate, like in terms of setting yourself up for success for that particular procedure, whatever that procedure is?
That's a great question, Sam. And I think we all have our own um, procedures for what we do. First of all, as you know, the success of an operation starts well before you operate. It you have to think about your approach. The incision is very important. And I always tell the residents, anyone can sail on a calm day. It's sailing in rough seas that differentiates the sailors from the amateurs. And when I go into surgery, no matter how simple the procedure, I really, in my mind, have 2 or 3 alternates in case I encountered something I didn't anticipate. And as a result of that, so it's all in the preparation. My incision is going to be key because it's my initial approach, but it also incorporates any fail safes that I may need. And then after that, we're truly done. But I still do scrub prep. And that's old school because, as you know, Sam, one infection, it's devastating. It's really devastating to get a surgical site infection. So I try to avoid that.
So you mean
And
scrub prep, meaning you do a full scrub as opposed to, say, just like the chlorhexidine stuff that
yeah,
yes.
yeah, I'll do
Yeah.
it. I'll do a scrub, and then I'll do chlorhexidine, or if it's an open wound, I'll do betadine. And I'm really kind of manic about that and about the draping. Um, and other than that, everything is fairly routine. For hand surgery, you use 4 drapes. It's
Mhm.
not hard.
Mhm.
So you do the same thing every time.
Now, it's so interesting. I don't think I've met a surgeon yet who has not talked about pre-visualizing the procedure at
Mhm.
length prior to operating. And I
Absolutely.
and I do know from my previous experience way back when in hand surgery, your incision and your exposure is everything, because you can burn a lot of bridges or hurt
Hmm.
yourself tremendously if you don't make that right incision. You could really screw up your operation. So I forgot about that actually until you reminded me. And I was like, yeah, that's right. That hand surgery is really about that. Um, so uh, when you do your setup, and you're in the OR, what do you listen to? Do you have a particular type of music you prefer, or something you
So
like?
music is always, and it's funny, Sam, you think of how it evolved. I remember as a general surgeon, we used to bring those 5 CD changers and
Yep.
the nurses change the CDs out.
Yes. Yes.
And then, of course, iPods changed everything. Like, how in the world can you get 10,000 songs on a thing that's, the size of a matchbook? A matchbook. So I have playlists that I've developed, and there's nothing from the 21st century. It's only from the 20th century. So I have my 60s, 70s mix, my 80s mix, which is alternative, and then my 90s mix. And then I do read the room. And if it's only millennials or younger, I'll ask them what Pandora or Spotify station they want, and then I'll humor them. Because I just think, to me, it really doesn't matter what I'm listening to. I'm not so much a rap gangster person, but there's a subset of people at Valley Hospital that love country. So I've been listening to country. Admittedly, I still don't get it, but I don't mind it. It doesn't bother me.
That's so funny. I do remember when I was a resident, I would, at that time, music was important. So I would bring big albums of CDs with the CD player, ask people to play. And there was one vascular surgeon I remember in particular. He only liked 3 albums. So we listened to Dire Straits. So we listened to Dire Straits, Brother in Arms,
I remember
some Broadway thing like Man of La Mancha. I don't know why, and I forget what the third one was, but like it was on repeat. So if we had a really long vascular procedure, you really had to like that music after a while. So it's nice that you're very flexible in that sense, and
absolutely
you are considerate of the others in the room, because I think you're right. I think it's really interesting, actually. I hear a lot of different responses in terms of music, and yours is very considerate, and I wouldn't expect anything less from you about that. So who is particularly important to you, say either in your OR or as part of your whole team, like, Team Rabinowitz, in terms of you as a surgeon? Like, who really helps you function your best as a surgeon?
Yeah. I know we kind of talked about this a little bit and touched on it. For me, it's a little different because I don't work in a surgery center very often. I have over the last 20 years, and there was there's the same people I work with, but I'm not so reliant on having the same scrub person or the same circulator. I am very flexible. My preference card states very specifically what I need. Obviously, I'm really impacted by inexperienced scrub tech. It's hard, especially when you do micro. That's very difficult. So I do have a couple of PAs in my practice I work with, and I found working with them has been terrific because they know what I like. They can almost mirror my moves and anticipate what I'll need next. And that does make the operation a whole lot easier.
Do they scrub in with you?
That's one area where I think when you're doing micro and you really can't look up from the scope, and you really just kind of put your hand out and say, give me the needle holder, give me the scissor. You want the right instruments handed to you.
Now, they scrub with you at all of the hospitals that you work out of? Okay. Wow. That's great. Yeah, that's huge. So, is there any particular operation you really love doing still? Like, you really get a ton of pleasure from?
It's funny. That's it. Well, let me ask you, do you have a favorite operation first?
I have, when I was a craniofacial guy, I really loved cleft lip, obviously. And I still do that when I travel, go overseas and do surgery, but, I don't do that in my regular practice anymore. I would say, probably, I would say for younger patients, it's really about impact on the patient, right? So I think for me, it's not so much like the technical wizardry or, feeling flashy or cool as a surgeon doing a particular operation, which certain operations I used to feel that, like a really technically difficult operation would make me feel like I'm a real surgeon. Now it's like, what kind of impact am I making? And for young patients on the aesthetic side, honestly, it's a breast augmentation. Like, that makes people feel very different. Like, and maybe it's a very simple impact, but it's a pretty powerful one. And then I think in older patients, it's probably still in a abdominoplasty, like a really nice tummy tuck. Like for patients who've had multiple children, like that's very impactful for them. And like I said, it's really not about, is it a tough operation, easy operation? It's just, what kind of change are you affecting? And these are changes to me that they can't do themselves. So no matter, like, there are a lot of things that you do in body contouring, for example, which, you know, the patient can really help you out a lot if they really, you know, did some fitnessing or nutrition or whatnot. But you can't exercise yourself into larger breasts, and you can't diet or exercise yourself into getting rid of all of that extra skin that has developed after 2 or 3 kids. And so these are, you know, powerful changes that you are helping them make, regardless of what they can do for themselves, probably. So.
And to add on to that, you know, I still do some cosmetics. It's not the bulk of my practice, but I enjoy it. And the operations you just mentioned, let's say breast augmentation, tummy tuck, even I'd say breast reduction, those are operations that are easy to do, but hard to do well.
Yeah.
And it's different. And there are nuances in that. And that's with experience, you really get better at that. You know, it's instead of just putting the biggest implants you can put in there, you have to look at the person. Most importantly, listen to the person, see what they like. And you're right, it does change them dramatically. In terms of and I agree with you about the whole technical thing. Like, I remember when I first started, you know, doing a replant that's successful is amazing. Being able to put someone's fingers back on and have them work is amazing. Now, realistically, we know that when you put fingers back on, depending upon what the zone of injury is, sometimes it looks good but doesn't function well, and that's hard. But also, like, a perfect example is I work with the cardiac people quite a bit at Valley Hospital, and I do a lot of sternal wounds reconstructions, and it's a fun procedure for me. Technically, it's, you know, something where it's terribly difficult, but it's something that we do as plastic surgeons and they don't do. And you're essentially saving someone's life. I mean, someone has this cardiac surgery, they have an infected mediastinum, you're looking at their heart, and you can move muscles around and skin around and get it to close and get them to walk home. So that's very satisfying.
Yeah. I think. Go ahead.
Go ahead.
No, I think you're right. The thing that just struck me was what you said about what the best surgeons do, the experienced surgeons do, is do the common things uncommonly well. So when you do something, it's, like you said, easy to do. Like, I remember doing not many, a fair amount actually, of sternal wound closures, but it's doing them like efficiently. Like, there is a grace and a elegance and a beauty to doing a very simple, like, it's not simple, but like you said, not technically difficult thing, straightforward, really well. That is the mark of a great surgeon, I think, and not overly complicating things, because I think, especially when I was a younger surgeon, I would try to make it a bigger deal sometimes than it was, instead of really getting to the heart of it and addressing it and making sure that it wasn't that I did it with a minimum of effort as opposed to a maximum of effort, maybe.
Right. And as you know, with these procedures, especially, let's say, sternal wound reconstruction, the big error that we, on the whole, as surgeons or plastic surgeons, the biggest error we make is actually inadequate debridement.
Yes,
you know,
that's still the number one problem. Still?
It really is. It still is. Because we're so focused on harvesting the muscle and getting the pedicle on the muscle and moving the skin, that stupidest thing is, if you do inadequate debridement, your operation is doomed to failure. And the easiest thing to do is debridement.
The funny thing is I remember very vividly as a resident, the old graybeards in the room saying that and growling it. And That wasn't, debrided back properly. Yep. And I remember being yelled about that by not clearing out the sternum adequately enough in a case, getting back to healthy tissue. And I hear that in Eminem still. I hear Rick Winters yelling about that, especially in complicated lower extremity trauma. And to hear you say that, like, it validates the fact that we probably have all tried to get away with it when we were younger, and it always comes back to bite you. And so these lessons, like, biology is still biology. It hasn't changed whether it was, 1990 or 2024. Like, you can't make human tissue, different in terms of how it responds in that way.
Right.
So,
And it's the same thing with dealing with, implants, breast implants or other implantable acellular dermal matrices. If there's infection, you can try to gild the lily, but if you're unsuccessful, eventually you have to learn to be a grown-up and take it out and tell the patient that and say, look, I'm really sorry that you can't have your breast implant, but we will go back when it's safe and do it. And that's hard because they're paying customers and they're looking for a result. And that's
right.
very difficult for us, but we have to sometimes.
Well, let me ask you this. So you are one of the plastic surgeons I really admire and look up to in terms of how you interact with other plastic surgeons as well as your patients. You truly are, like, I would never have pegged you for an engineer because as a STEM person, you have a tremendous amount of empathy and sensitivity and kindness when you talk to people. Was that something intrinsic, or did you help hone that? Like, did you learn some skills as a surgeon coming in? Like, I have had some surgeons who said they were kind of not such great people surgeons, and then they developed those skills over time. Like, how did you get to where you are in terms of how you interact with people?
Well, it always reminds me, my favorite joke is, how do you know when an engineer likes you? And the answer is, he stares at your shoes.
It's good.
So engineers do have this, reputation of being probably a little bit on the autistic spectrum. In answer to your question about my personality and how I interact with patients, how I interact with others, and how I interact as a human, I'm just fortunate. I'm fortunate that because autism you're born with, right? And the way you interact, it's, obviously some of it is socialization, how you grew up in your family, all your life experiences. But I think part of my success as a surgeon, and I tell a lot of people this, is my ability to speak to people. Not only to speak to people, but to speak to patients in clear English, not technical, to look at them when I'm speaking to them, and even more importantly, know when to stop talking so I can hear them talk. It's amazing how much that makes a difference, and how much patients will respond to you when you actually engage in two-way conversation in English.
How do you deal with conflict? Because one of the things I've seen you do, and we do as plastic surgeons, is there is always some conflicting interests. There's always, we all have our own self-interests. And every time I meet with a bunch of plastic surgeons in most of our hospitals, there's always a little bit of headbutting or complaining about this, that, or the other thing, or, railing against hospital administration or this, that, or the other thing. And this is not any different from most jobs, I would say. Like, most jobs probably find some similar types of situations or analogous situations. But you have a good way of mediating or sort of working with people that I've seen. How is your approach to that, especially when you have these honestly, a lot of plastic surgeons have pretty big egos. They're smart. They're well trained. How do you deal with all these people when you're sort of, handling conflict in your situation?
Well, if I make it look easy, I assure you it's not. And you're right. You are dealing with personalities. I try to look as objectively and as emotionless when I approach a problem as possible. I'll use whatever data and other information that's available to me to help mediate the problem. Like a perfect example, as director, and because you were the assistant director for quite some time, I first of all, I will always talk with the administrators. I'll refer to the bylaws, and I'll see if we are behaving within the guidelines of the bylaws of the hospital, and I'll let current dogma, current rules and regulations help guide me. Does it always help? No. We have problems now, as you know. And there's not a single plastic surgeon that wants to take call at any hospital at any time now.
Yeah.
But that's difficult, and it's necessary. So it takes some cajoling sometimes. Other times I defer to hospital existing guidelines and bylaws. But that's a very specific thing that I'm talking about. I just try to mediate using whatever knowledge I have, treating the other person as an important and respected person as well, seeing their perspective, but also if I have to be firm, I have to be firm. And there are people that, let's face it, they're absolutely dead wrong sometimes, and they feel as if they have some entitlement, and that's not fair to the others.
Your schedule, how has that changed over the years? Because honestly, from the outside, it looks like it's as busy as ever, maybe busier. Like you still take a ton of call, and everyone knows how crazy that can become, especially since you are one of the few go-to hand people in the area. So how do you maintain a good quality of life schedule as you progress? Because a lot of people at this point would be like, this is nuts. I don't want to do what I did 10 years ago or 15 years ago in my practice. But it seems like you're still going strong. Like, are you on methamphetamine, or like, how do you maintain your energy level to keep up this kind of schedule?
I don't think any of the drugs I use are illicit, but they may be off brand. Certainly, I may use it for a different purpose. No, but ever since I'm young, I am not sleeper. I am not someone that required a lot of rest. Even as a high school student, it was crazy. So I am relatively high energy, but I'm almost like a moderate amount of energy that goes for a long period of time, as opposed to someone who's high energy and then burns out. Regarding, my practice has changed over the past 10 to 15 years. There are some procedures I don't do like I used to do. Rhinoplasties, I don't do those anymore. I don't prefer to do replants or micro cases, so I've really kind of cut back on those. I'm actually phasing out call at one of the hospitals, and the other hospital I'm only taking about 3 per month because I'm required to as an active staff member. And I do think that call has gotten a little better after the No Surprise Act went through, and the ERs. Again, this is very specific to plastic surgery. I'm not sure all your listeners would know about this, but we're not getting reimbursed anymore for these vanity calls, and as a result, it's hard to get not just me but any plastic surgeon into the emergency room. If they know they're not being not only reimbursed fairly, they're not even being paid for these things anymore.
Right.
So that's part of the issue. But obviously, if someone has a dog bite to the face, has a bad injury that requires our expertise, paid or not paid, charity care or otherwise, I'm going in. I'm going to help. There's been a few ortho people that have called me in where they've had particularly tough cases or replants, and I've gone in and helped it. And I find that because I have an expertise, because I have a few gray hairs, because I've seen it before, ultimately it helps the patient, and that makes me feel really good about what I do.
So how does work-life balance figure into your future goals as a surgeon? So you're still extremely active. We know surgeons who have been very active for quite some time. So as a surgeon, like some of your mentors actually too, like the people back in when you were training. So what are your goals as a surgeon at this point? in your career?
Okay. Well, I still enjoy what I do, but I recognize that aging is not a myth. Aging is real, and I know at some point I'm going to slow down. Um, in terms of my horizon, I really haven't thought about it because I still enjoy what I do. But in terms of work-life balance, I do feel that I feel very balanced. I have two wonderful kids. I'm married. My wife, we have a great relationship. I have four grandchildren, and I see them quite a bit. At least every week, I see them, 2 or 3 times a week. So I always like to say I work hard and I play hard, and it's a balance that works for me, and most importantly, works for my family. I don't think they feel as if I've neglected them at any stage of their life.
Do you feel like you're going to take on more administrative responsibilities versus clinical in the future? Like you've already taken on quite a few administrative responsibilities. Do you plan on taking more?
No, because as much as I enjoy being a director, and I think that I'm an effective director, and I think I'm a fair director more than anything, there are periods of time when it's a thankless job. And if you put a gun to my head and said, would you rather be at a board meeting or in the operating room, listening to, a nice 70s, 60s mix and hanging out with a PA and a scrub tech and a circulator, that's what I'm taking every time. I mean, that's much more enjoyable for me than anything administrative.
So then how much longer have you thought about doing surgery? We know surgeons who would literally operate until like old draft horses, just, drop in the harness dead, with a scalpel in your hand. Or some who figure out some sort of exit plan and like know that at some point, this is whenever I feel like it, maybe not right now or not right in the near future, this is what my future holds for me.
Well, I'm clearly closer to the end of my career than the beginning. This is 28 years for me. I'm in my early 60s. So I can't imagine doing this much past age 70 or 75, but probably 70 is a better number. But I am not absolutely holding myself to that. It's more about, and also we can scale it, Sam, which is nice. We can work 3 days a week if we wanted to. We can work 2 weeks and then take 2 weeks off if we wanted later in our career. And if I felt that that was necessary or it was better for my brain at that point, then I would certainly do that. But right now, I'm very comfortable working a full schedule. But again, it's 3:30 in the afternoon when we started our conversation, and I was home and you were out of work, so that's a good thing, right? When I first started, I would have been in the hospital till midnight. So you're not always like that.
If someone were to hear you and say, you know what, that is what I want to be Dr. Rabinowitz in the future, like what kind of advice would you give them for them to be or to think or have a mindset to sort of get there for you?
Wow. I talk to medical students all the time. I talk to college students, and talk to, friends and family about this all the time. As you know, medicine is not an easy field. It's a field in which you have to commit yourself, and you really can't do it halfway, in my opinion. And my career path within plastic surgery, as you know, is a little more unusual. If you're a craniofacial person that focuses on, at this point in your career, more cosmetics, and that's what you do. Whereas I do probably about 65% hand surgery, and the rest is mostly reconstructive and or cosmetic plastic surgery. But for me, I've always enjoyed the variety in the mixture. There are some orthopedic surgeons, all they do is knee replacements or hip replacements.
Right.
But if that's what they like and they like that routine, that's great. But I probably have, a couple of hundred procedures that I do. And you could tell because when you go to some of the orthopedists, when they finish with a case, they already have their pre-dictated op note because they do it the same time every time. And I don't, except for maybe carpal tunnel and trigger fingers. But otherwise, it's a new adventure every time. And it's a little nuanced and a little different. So I like that. So if I were to offer advice to someone, I would say, first of all, you never go into anything because of financial compensation. Go into something because you enjoy it. The hard part, of course, as you and I know, is trying to figure out what you enjoy. Most people don't come out of the womb and say, I want to be a craniofacial plastic surgeon. It's by life experience. But I think, the what's the phrase? If you do what you love, you never work a day in your life, right?
Right.
But if you do what you love, it's certainly a whole lot easier to wake up in the morning and go to work and be a productive, member of our society, for whatever job that would be. I do think that what I do in terms of doing both hand surgery and plastic surgery works for me, but it's more unusual.
Yeah, you are a classic plastic surgeon in the sense that you feel comfortable doing such a range of things. And nowadays, most of us will hone down pretty quickly and let all the other skills atrophy. Like, there's no doubt it used to be, and I probably still is, when you come out of residency training, you feel like you could do everything, right? You can do an orbital floor fracture. You could do a metacarpal fracture. You could do a sternal wound closure. You could do lower extremity. Like, you could do a free flap for, a severe tibial injury. And now it's like, you come out and then you hone down pretty quickly, and then all those other skills you had kind of fall away, but you still do the range, which I think keeps you interested, keeps you stimulated. I think if I had to put my money on someone who would least be likely to develop dementia as they get older, it would be you, because your brain has constantly been stimulated by, working on all these operations, as opposed to, say, the ortho guy who does the assembly line, knee. So, so that's pretty awesome.
Yeah, it does keep it does keep my mind fresh, but also, there's a phrase that jack of all trades, master of none. And I always worry about that. So I do tend to focus more on the hand surgery for that reason. And as you mentioned, we all did so much in residency, and I quickly dropped maxillofacial trauma, because even though I enjoyed it, I just felt like I wasn't expert in it. And I didn't want someone to get an ectropion or entropion. And even now, I'm shying away from various cosmetic things that I just don't do as often as I did. Certainly, as I told you, I stopped doing rhinoplasties because I really feel that's one area where you really need to do quite a bit, and before you have a comfort level.
Yeah, I loved rhinoplasties, and obviously I felt very comfortable with them, but I dropped them too a couple years ago, just because either you had to be all in on them and do a lot,
exactly,
or because that is something that I respect tremendously, and you have to know where you stand on it. So I agree with you. That's so I personally feel very much like you do about figuring out where your strengths are, what I do. And like I said, it's not that I don't feel like I've lost my touch. It's just, listen, when you have to do something, you got to get your reps in. And if I'm not getting my reps in, then I'm doing a disservice. So I want to, and you make choices in your practice. So had you chosen, I want to still maintain an active rhinoplasty practice, then you push for that. And we all know, we can develop any part of our practice that we so choose. It's just where you focus your energies on. And that wasn't something I wanted to focus and you make your own choices as well as a plastic surgeon in that. So that is
absolutely. And as you know, with rhinoplasties, you can do a perfect rhinoplasty and unfortunately get a suboptimal result. Now, you could make the argument that if you did 1,000 of them, you would get less suboptimal results over time. And that's what probably I was experiencing. I just wasn't doing it often enough.
I always felt like I could do a rhinoplasty. Like I have a
Mhm.
way of doing a rhinoplasty, but
Mhm.
all of the subtleties in terms of like the different ways of modifying it or changing it, or if it wasn't exactly what this patient needed or wanted, like maybe their anatomy was slightly different. Like, so I could do a, a vanilla rhinoplasty, but anything other than vanilla, if you wanted mint chocolate chip or, strawberry, like I was like, I don't know. I don't, that's not my alley. And like you said, you do 1,000 of them. Yeah, then you can offer up every, variation that you needed, but it was one of those things that like, yeah. So I agree with you on that.
Yeah. And
Um,
even now, like, my partner is Hakan. He's on Hakan and Carrie Cohen have done maybe about 2,000 deep flaps.
right.
Okay. After 2,000, they are really good at it. So if anyone came to me and said, I want a deep flap, I'm not doing it. I'm giving it to them.
Yep.
Okay. Because after 2,000, you have a pretty good handle on any problem you could encounter.
Absolutely. I mean, we all know, I think, especially in our areas, who really focuses on what and who we
Mhm.
know who is expert at it. And I've relied on you for so much of that over the years, and I really appreciate that as well. So,
Well, thank you very much. And I admire your work and your work ethic. And uh, it's been terrific working with you and being a colleague of yours for all these years.
thank you so much, Sid. I really appreciate you taking the time. I know how busy you are and with you and your life and as well with your family. So thanks again. I'll see you around. We do all the Zoom conferences now, so I'm sure I'll see you at the next M&M. But thank you again. Much gratitude to you.
Very welcome. Thank you. This has been a pleasure. All right.